Hi, I'm Katie Napton. I'm a community representative for Physio First, and I'm really delighted to have with me Will Gregory, who is a consultant physiotherapist working for the rheumatology team at the Care Organisation. So, Will, you're also the co-chair of the clinical interest group for rheumatology, which I know you will probably want to mention. And the reason you're here is because you've kindly written a wonderful article highlighting some issues that we need to upskill and recognise in rheumatology recognition. So we're going to have a little chat about that as well. But is there anything else you want to say about yourself first, Will?
Well, hi Katie, and hi everyone who's logged on or watching this after the event. Really nice to be invited to contribute the article for the Physio First Journal, and hi Katie, thanks for inviting me along and to the team. I think it was an important story to tell, and I think it's always worth that nudge about how we pick up inflammatory MSK or rheumatology diagnoses. Other things I wanted to say, we've mentioned the clinical interest group, and I'm not here to advertise, but we are a
Oh,
new
go on, Will, you can advertise.
we've been running since September 2021, so we are looking for anybody who has an interest in rheumatology to join up, and we're on about 250 members at the moment, which represents physiotherapists who work in rheumatology departments, of which we think there's maybe 100 or so across the UK, but the majority now are those physiotherapists working out in the community or in other places where they will pick up the early presentation of rheumatology diagnosis, and that's the core audience for this. For us, really, is that we can kind of improve the patient journey and massively decrease the problems with delayed diagnosis that we see in these conditions.
Well, absolutely. I mean, that's why I am a member. As always, like to be a member of everything, and I think it is vital. So, the core of this article really is recognizing that early inflammatory arthritis signs and symptoms. So, do you want to just sort of talk us through a little bit more about how relevant this is and why it's necessary?
I mean, I think it's probably mostly related to the fact that we now have treatments that help and can make a massive difference to people living with inflammatory arthritis. And, you know, if we'd have had this conversation 20 years ago, we'd both still be in school, obviously. But in addition to that, we'd be discussing, and not sure I would have been actually, we'd be discussing the fact that, you know, we haven't really got much help with these patients, and we get them exercising, we try and keep them active, and if they're having a flare, we look after them. But 20, 25 years ago, the landscape completely changed with the biologic medications, and we've now got treatments that do really work. They do really control the active inflammation, and therefore we need to get people on these treatments as soon as possible, and we get much better outcomes for patients that are seen early and treated aggressively and get access to these novel medications as soon as possible. So whereas 20, 30 years ago would have said, we kind of want to see your patients because we might be able to help them a bit, the story now is we're desperate to see these patients and as soon as possible because we can make significant differences.
Yeah, and I mean, that's really apparent, isn't it, with the rheumatoid arthritis, especially. I mean, when I was training, I remember seeing, you know, a young girl who's having bilateral knee replacements and you know,
Yeah.
things have moved on hugely. So you particularly covered rheumatoid arthritis, axial spondylitis, arthritis, and psoriatic arthritis. So shall we talk a little bit about each of those quickly and
Yeah,
just do a little
absolutely.
brief summary? I think that'd be really helpful. So if we talk about your axial spondyloarthritis first, what is the sort of delay at the moment for diagnoses?
So there's a big push from the National Axial Spondyloarthritis Society, and they're sharing the data as about 8.8 years across the UK. So it's a massive delay from that first hint that there's something wrong to actually seeing the rheumatologist who gives you the diagnosis, or the member of staff from the rheumatology department who gives you the diagnosis, I should say. So that 8.8 years is really quite significant, and particularly when we consider that axial spondyloarthritis tends to present in your late teens, early 20s. So these are people who are forming their careers and making those early relationships and doing all the fun stuff you should do in your early 20s, who can be severely limited by active disease. I should say at this point, we're calling this axial spondyloarthritis, which is a broader category for the diagnosis that perhaps the older of us might have been trained on as ankylosing spondylitis. And please do look at my article, and there's a nice little Venn diagram, and I do love a Venn diagram if I can share one somewhere, about where ankylosing spondylitis sits within the broader diagnostic category of axial spondyloarthritis. But it's better to use that term, axial spondyloarthritis, now, because it covers more patients, and particularly it covers more female patients. And by considering it as a broader term of axial spondyloarthritis, we've now got a 1-to-1 ratio of male to female within that diagnostic group, whereas ankylosing spondylitis was always considered a male problem. Absolutely. 7-to-1, 3-to-1 maybe.
Okay, so that's interesting in itself. So we know, so there's a huge delay there. And what about rheumatoid arthritis?
Yeah, I mean, less of a delay. Yeah, absolutely. It probably because it is a bit more apparent in its presentation, and certainly with rheumatoid arthritis, we'll get blood tests that can really help us, whereas with axial spondyloarthritis, the blood tests are more of a hindrance than a help, because you more often see a negative blood test than a positive, and that fact can push the diagnosis down the line. So certainly from a blood test point of view, you'd expect to pick up rheumatoid arthritis sooner, but also the nature of how it presents, and it's usually the smaller joints, hands and feet, which we notice if our hands aren't working, and we notice if we're struggling with walking, whereas the back pain or sacroiliac pain that tends to be one of the initial presentations in axial spondyloarthritis, either we don't notice it, or we're so used to the narrative of everyone gets back pain, you just have to keep moving and keep on with it, that we're less good at picking this up, both in ourselves if we're developing it, but also us as healthcare professionals. That narrative of chronic non-specific low back pain, it's great that it's out there, and it's completely appropriate that it's getting us to manage back pain as a broader diagnostic category appropriately. But when you do get that small percentage who have an inflammatory back pain, it can be missed. Whereas the rheumatoid in the hands, in the feet,
the dactylitis is, yes, I have had a few video consultations with people presenting with dactylitis, and it is pretty obvious. And then, you know, the last one you talk about is the psoriatic arthritis. So what, and that, is it sort of, was it 40% actually have active psoriasis?
Prior to the diagnosis.
And that
I think 60% have active psoriasis prior to the diagnosis.
Yes, that's right.
And so 40% don't. Yeah.
That's right. So those are quite interesting stats. And there's a familial link as well, is there, in terms of...
Well, to get the diagnosis, the psoriasis doesn't need to be in that patient that you're assessing. Yeah. If there is psoriasis in the family, that is sufficient to support that diagnostic pathway, really. So we need to ask our patients, and I must say for me, I ask patients and they say, oh no, I don't have psoriasis. And then you say, oh, how about, do you have any dry skin anywhere? And they'll say, oh yeah, I've got a terrible flaky skin in my hair. And you go, oh, okay, can I have a look at that? And you're like, I'm pretty sure that probably is psoriasis. So again, as we are, as a culture, used to looking at back pain and going, it's just back pain, dry skin, we're probably quite good at kind of ignoring. So the psoriatic plaques are probably more distinctive with the redness there, and the characteristic areas where you'd find it, you know, in the hairline, back of the hair, around the ear, and a few other areas. So you'd hope the patient with psoriasis would be aware of it, but equally we now need to accept that the psoriatic arthritis diagnosis can be triggered by a blood relative who has psoriasis, and we're not going to have the blood relative sat in with us on that consult most likely. So it's good history taking that comes in there as well.
Okay, so that leads nicely into how would you recommend, so as we've talked, you know, it's recognised that a lot of private practitioners are sort of first port of call. They're out in the community with the difficulty in accessing GPs and getting face-to-face appointments. Quite often we are those frontline practitioners. So we get, you know, top tips on how we should go about without bombarding the patients with too many questions.
Yeah, and I do touch on this on the article, and I suppose the first thing is, you know, trust that gut instinct or that hunch that we all have. If we've got a few miles in the tank of patients we've seen, and if you're seeing somebody and you're thinking it doesn't quite feel right, sometimes you have to go with that feeling. And as soon as you have that feeling, that triggers you then to dig out your checklist of questions about inflammatory arthritis, whether that's a physical piece of paper that lives in your clinic or something that lives up there, is according to how you do these things. But going with the hunch and thinking, well, this isn't quite right, particularly with the rheumatoid pattern where you've got kind of heavy prevalence of symmetrical presentation. So we tend to see patients with unilateral symptoms, don't we? And if a patient comes in with wrist pain, and then the next week they're in with you and it's both wrists, and there's not an obvious mechanical cause, that in itself should trigger a little bit of a, I wonder. And as I said in the article, I think culturally, as a group of MSK clinicians, we've become really good at asking the cauda equina questions. And I think that's absolutely brilliant. And I think it is definitely something that we need to do. But equally, can we now add those inflammatory arthritis questions? And whether it's the 3 questions about rheumatoid, or whether it's the 5 questions about axial spondyloarthritis, or the digging around the psoriasis issues in combination with some of those questions that are in the paper, having those as part of your general script would be fantastic, because they're short questions to ask. And at least if you can reassure yourself you're not suspecting an inflammatory arthritis, you then move on and do the rest of your job.
And then again, there may be ones that you come back to later if it, at that time they didn't sort of recognize what you were asking, because that sometimes is a problem.
Yeah.
I think
that's
and then there's all sorts of information out there, isn't there? And your article contains some really nice, I like your SPINE acronym, I think that's useful. And then there's the SPADE tool as well, which you highlighted, and then obviously there's lots of information on the NAS website, as well as a public facing tool to test, is that right?
Yeah, this is going to be really interesting. So NAS have developed this public facing tool where I think it's 8 questions, that they put into the symptom checker. And as long as the person consents and therefore GDPR is covered, their record is then held. So anybody who goes onto this online form and puts in some answers to the questions, they'll be then followed up yearly, every 10 years, and we'll see actually did they then develop a diagnosis sometime within that time frame. So the people that are asking questions online, the general public who are, how many of them actually convert, and therefore how good's the tool, but also kind of feeding into the epidemiological data of how prevalent is this condition. And there's certainly a percentage of all 3 of those arthritis that we talk about in the paper that never present because it's a milder version, or they don't notice it so much. And actually, are we missing some of our potential benefits by not being able to pick up every single case?
So future will tell us something. Hopefully we'll be able to sort things out more. So in terms of thinking back to these, us as private practitioners and potentially some of us as sole practitioners, any recommendations? So I think you're right, we familiarize ourselves with the questions because they're simple, they're easy, and we get a decent picture. But any hints or clues of what to do then? Because obviously we're working slightly in isolation.
Yeah. And I think that's the tricky bit is the paper we did in Salford, where we looked at 50-ish patients and their journey to diagnosis. We did find, I think about 60% had seen a physiotherapist prior to getting diagnosed. And I suspect at least half of those were in the private sector potentially. So these patients are turning up and we are culpable of not getting them diagnosed early. And that could be despite your very best intentions in private practice or in a kind of arm's length organizational structure, because your queries aren't listened to or aren't followed up, and that kind of lack of linkage can be problematic. And the article has a fantastic section by a Katie Napton, who I'm glad to see is joining us today on this webinar as well. And you have pointed out the NAS tool, which is a really nice idea of this template of how you write to the GP or how you write to the rheumatologist, if you're able to say, these are the things I've found, and this correlates with the guidance from NICE with regards to potential early diagnosis. So yeah. I think having that kind of a template is useful, but I would also say, don't be afraid to build a relationship with your local rheumatology team. We're all very busy, but we're also very passionate to get the patients in early. And if you've got that, even if it's a query patient or just an interest yourself, do get in touch with your local rheumatology team, and particularly the early inflammatory arthritis team, because we know we need to sift a decent amount of referrals to make sure we get the gold of the early diagnosis, if you see what I mean. And that triage process means that we will probably 50% of the time see patients who end up not having inflammatory arthritis, but we would rather see them and reassure ourselves than if we had a service where 100% of the patients referred in all had inflammatory arthritis. That would make you very concerned that you were missing some.
Always going to be missing. No, I think, yeah, and I think certainly from personal experience, I think it's really raising that awareness of the NICE guidelines. So having that, the CKS app from NICE on your phone, so that you can state everything out to the GP,
Yeah,
why you're
yeah,
suspicious. So you really spoon feeding what you're hoping to come out of it, and it's not just you're picking something out of the dark. This patient's just not getting
yeah.
better. That
And the
you're really,
more the
yeah, the
more you
more
can have
information you gather,
8
the
out of the
better.
10 options that you cover. It's really nice at the end of the spondyloarthritis NICE guidance. It says, do not rule out a diagnosis of spondyloarthritis based on either one negative or one positive. So your GP can't send back to you a letter saying, well, they can't have it because they don't have early morning stiffness, or they don't have a positive blood test, or whatever else, because it is about having that kind of 4 out of 5 or 8 out of 10 of the different indicators for each of those diagnoses that pushes the balance to make that referral, rather than any simple yes no answer to any one of the questions, either opening or shutting that door.
So, well, Will, I'd really like to thank you for your time. And, this is something that is, hugely important. As you say, we make a real difference to people's lives the quicker we can pick this up. So thank you so much for helping and your passion for the subject. And well, I think you'll leave your details in the article, and people can contact you if they've got anything to say. And if people can join the clinical interest group, I'd highly recommend, as we all have a part to play from whatever area of physio we come from, whether it be the private or public or whatever independent sector. So thanks, Will. It's been great to catch up with you, and I look forward to watching your work as you carry on, because you apparently seem to be doing things are happening.
Yeah, lots of exciting stuff in rheumatology. So yeah, as I say to anyone watching, please do consider joining the clinical interest group. Have a look at the article. And I would say anecdotally, we kind of need to remind ourselves about this every 6 months or once a year. Oh yeah, those are the things I need to be asking. Because if you don't see a big cohort of inflammatory arthritis, you do get out of the habit of asking the questions. And it could be a poster in your weight room or in your clinic room. It could be something on your phone, as you say, Katie. But do keep fighting the fight for rheumatology for us. We absolutely are amazed to have brilliant MSK clinicians out there finding these diagnoses. And I think as we see GPs struggle to see MSK, we will see more and more different healthcare professionals getting involved in that diagnostic pathway. And I think, without wanting to slate GPs, we actually will see improvements for having a broader workforce involved in picking things up.
Oh, let's hope so, for the patient's sake, anyway.
Absolutely.
Thank you, Will. All
Thanks
right.
for your time.